Hello and welcome to the Psychopharmacology Institute. You are listening to expert consultations where we interview elite faculty about clinically relevant topics and updates in psychiatry. I am your host, Dr. Radwa Hanafi, and today our topic is navigating insomnia in major depressive disorder and discussing advances in management. I would like to introduce our expert for today's discussion, Dr. Amit Chopra. Dr. Chopra is a psychiatrist and sleep specialist currently working at Massachusetts General Hospital, Harvard Medical School. We are delighted to have you with us today, Dr. Chopra.
It's my pleasure to be here today.
Great. So, in the lecture, we learned about cognitive behavioral therapy for insomnia, or CBT-i, which is the first-line treatment for insomnia. How does it compare to pharmacological treatment, especially for patients with a prolonged history of severe insomnia?
CBT-i has been compared with medications in research studies, and it has been found that it is equally effective as compared to medications in the short term, and it has superior effects in the long term, which means that this is a durable treatment which can last its effects for up to 3 years as compared to medications where the effects start to disappear after stopping the medications.
Wonderful. And from your experience, which patients are most likely to benefit from CBT-i and demonstrate positive outcomes?
Sure. The ones that do not benefit from this treatment are those with short sleep, especially with total sleep time of 3.5 hours or less, those with a history of depression and head injury. And the people who would benefit from this intervention is those who have longer sleep times, those who have reduced use of hypnotic medications, those who have maladaptive behaviors such as spending a lot of time in bed when they're not sleeping, those who have adequately treated psychiatric comorbidities such as anxiety or depression, and a greater willingness to use CBT-i as a treatment intervention.
Now, digital CBT-i is FDA-approved. Could you please explain how it would be implemented? For example, does it involve apps or telemedicine?
Sure. Digital CBT-i was approved by FDA in 2021 for treatment of insomnia. So the digital CBT-i can be implemented in a self-guided format or automated guidance format. The self-guided format provides access to CBT-i techniques, but it may not provide personalized and tailored treatment recommendations. Whereas the guided platforms offer CBT-i techniques and may use AI technology to offer personalized treatment recommendations. There are several apps that are used for CBT-i, but only one of them is FDA-approved, and that's called Somryst. It needs a prescription through a physician before using this app. And digital CBT-i has been compared with placebo, where it is way more effective, and it has also been compared with medications and traditional CBT-i. And we do notice, based on a recent network meta-analysis, that it could be one of the most effective treatments in terms of achieving response for insomnia symptoms based on subjective monitoring tools such as Insomnia Severity Index.
That's interesting. I think it's my first time to hear about an app that needs physician prescription, which is Somryst. So let's shift gears and talk in depth about our topic, which is insomnia comorbid with major depressive disorders. How do we effectively distinguish insomnia as an independent condition from insomnia that may manifest as a side effect of antidepressant medications, for example? And how would you manage insomnia when it's identified because of such treatments?
Antidepressant treatments are likely to cause insomnia. In fact, 17% of the people who take these medications have been known to suffer from insomnia complaints. So it's very important to psychoeducate the patients who are taking antidepressants that insomnia could be a side effect. An important thing to examine here is to establish a temporal relationship between the start of the medication and onset of insomnia symptoms. When this condition happens, there are several strategies to address it. One is to change the timing of the medication. Sometimes medications taken in the nighttime can cause more insomnia than taken in the daytime. The second approach would be to reduce the dose of the medication. The third would be to finally switch the medication to a different medication that may not cause such symptoms.
Understandable. And what are your recommendations regarding disturbing dreams related to REM rebound upon antidepressant discontinuation?
Antidepressants act by increasing the neurotransmission of serotonergic and noradrenergic receptors. And surge in these neurotransmitters leads to REM suppressant effects. So what happens when we stop the antidepressants, there's a REM rebound, which is characterized by increased REM sleep percentage during the nighttime and increased REM density, where people can have increased eye movements during their REM sleep. And this is associated with increase in dream content and disturbed dreaming. So the approach here is to advise the patient that this is self-limited and slow taper of medication may be helpful in these situations.
And how about patients suffering from depression and insomnia who are prescribed benzodiazepines? What are the possible or potential risks in this patient population?
The potential risks are not any different from those who are prescribed these medications for insomnia issues. And these include the risk of tolerance, dependence, rebound insomnia, and withdrawal symptoms. There's one more comorbidity that needs to be considered closely in patients with major depressive disorder, that is comorbidity with obstructive sleep apnea. Approximately 1 in 5 patients with major depressive disorder may have obstructive sleep apnea, which is treated or untreated, and prescription of benzodiazepines in patients who have untreated or unrecognized sleep apnea can be harmful as it can cause worsening of respiratory function. So it is very important to screen for obstructive sleep apnea in patients with major depressive disorder before considering trial of benzodiazepines.
So how should benzodiazepine dosing be adjusted for patients with liver or renal impairment, and which agents are considered safer for these populations?
The agents which are deemed safer in liver dysfunction include zaleplon, eszopiclone, lemborexant, and suvorexant, whereas zolpidem has been deemed to be safer in patients with renal dysfunction. However, a close monitoring is recommended for any potential side effects for use of such medications in these patient populations.
Let's shift gear and talk about DORAs, or dual orexin receptor antagonists. Which potential populations respond best to them?
Dual orexin receptor antagonists, or DORAs, are FDA-approved for treatment of insomnia disorder, and they can benefit patients with sleep initiation and sleep maintenance insomnia complaints. 3 drugs that have been approved in this category include suvorexant, lemborexant, and daridorexant. These medications, unlike benzodiazepines or non-benzodiazepine hypnotics, do not suppress the respiratory function, so they're likely to be more safer in patients with comorbid insomnia and obstructive sleep apnea. Similarly, patients with respiratory diseases such as COPD and comorbid insomnia might benefit from use of these medications. Lately, there's been some new evidence suggesting the safety and efficacy of these medications in elderly patients where the use of benzodiazepines or non-benzodiazepine hypnotics can be risky. DORAs have been known to cause symptoms such as sleep paralysis and hypnagogic or hypnopompic hallucinations. So patients who have existing symptoms like this may not be good candidates aside from those who have narcolepsy.
Perfect. So patients with delayed sleep phase syndrome can present with insomnia and may not be amenable to standard insomnia treatments. What is the best treatment for this patient population?
Delayed sleep phase syndrome is a circadian rhythm disorder caused due to misalignment of internal sleep clock with the light-dark cycle of the world. So patients with delayed sleep phase syndrome have a tendency to be night owls, where they can stay up late and wake up late, and this may manifest as insomnia, particularly sleep initiation insomnia. So it's very important to screen for sleep patterns, especially on the weekends, which could be suggestive of delayed sleep phase syndrome. And this pattern is more commonly seen in adolescents and young adults. The treatment differs from what we use in the treatment of insomnia, as we use low-dose melatonin, 0.5 to 1 milligram, 8 hours after the desired wake-up time on weekends or break days, and use of bright light therapy, 5,000 to 10,000 lux for 30 to 45 minutes in the morning time after waking up.
Wonderful. Let's move on and talk about the combinations of SSRIs and with antipsychotics or hypnotics for treating MDD and insomnia. Could you please share your perspective on the effectiveness of these combinations? And do you prefer one over the other?
Atypical antipsychotics are FDA-approved for treatment of major depression as adjunct to antidepressant treatments. However, these medications are not approved for treatment of insomnia. Amongst atypical antipsychotics, quetiapine has been researched more than others in terms of its efficacy and safety in treatment of insomnia in patients with major depressive disorder. The dosages for quetiapine for treatment of insomnia may include 25 to 100 milligram dosage at bedtime, and the decision to start this medication should be made only after a patient has failed the first-line treatment such as CBT-i or second-line treatments such as other FDA-approved medications for treatment of insomnia, or if the patient has treatment-resistant depression with significant sleep complaints and their clinical condition mandates the use of atypical antipsychotics as adjunct medications.
Great. So this was an amazing discussion. Thank you so much, Dr. Chopra, for this rewarding discussion and for joining us today.
It's my pleasure to be with you here today.